Thank you for staying with us. This is Good Morning Kenya. My name is Vivian Degwa. As promised earlier, we will be having a conversation on SHA, that is the Social Health Insurance. And our topic of discussion is just to get to understand the state of the Social Health Authority. And I am joined by one Mr. Gilbert Mogambi Osoro. He is the head public education and awareness and is here on the show just to help us understand everything concerning the Social Health Authority. Welcome to the program.
Thank you, Vivian, and thank you, KBC.
A much needed conversation. I'm sure you agree with me on that.
Totally.
Yeah. So let us just begin by you telling us what SHA exactly is, for someone who has no idea what SHA is.
Thank you, Vivian, and welcome, Kenyans. I want to take you and sensitize you what is the Social Health Authority. Allow me to take you down memory lane, because Winston Churchill once said that the farther you look into the past, the farther you see into the future. Social Health Authority is the successor of where we came from, that is the National Health Insurance Fund. Remember, the government of Kenya Kwanza, in its election manifesto, promised to implement 100% attainment of universal health coverage. To anchor those reforms in the statutes, there were a number of legislations that were passed. Key among them was the Primary Care Network, PCN Act. And this particular act provided for healthcare in level 2, which are health centers, and level 3 dispensaries, basically to offer a range of primary healthcare services, including inpatient, outpatient, screening, optical, amongst others. The next tier is the Social Health Insurance Fund, SHIF. Now, Social Health Insurance Fund is the successor of the defunct NHIF. For purposes of our viewers, NHIF became defunct on 22nd November 2024 when it ceased to exist as per the law established. And what we have now is the Social Health Insurance Fund that administers a range of benefit packages that our members can accrue. The other thing you need to know is the Emergency Chronic Critical Illness Fund, ECCIF. As the name suggests, emergency. When you look at the provisions of the Constitution of Kenya, Article 43, Sub-Article 1, it talks about that every Kenyan has the right to the highest attainable standard of health, including reproductive health. When you look at the Sub-Article 2, 43 Sub-Article 2, it goes further to state that Kenyans have the right to emergency treatment. In fulfillment of its constitutional obligation, the government passed the Emergency Critical Illness Fund to give a reprieve to Kenyans who are involved in road traffic accidents, who unfortunately have emergency medical needs. Instead of them having to put collateral for them to get treatment, they have the Emergency Chronic Critical Illness Fund. Those three funds that I've mentioned, the umbrella body is what we refer to as SHA. Vivian, you might have heard Kenyans saying SHA, SHIFU, and many others. But for the avoidance of doubt, the three acts which are administered under the umbrella of SHA, what is known as the Social Health Authority. Yes. Now, allow me to talk something on the rollout of SHA. If you recollect, last year, in the month of October, come October 1st, SHA rollout commenced across the entire country. And what was rolled out is the benefit package, which is very expansive. Unlike the 10 benefit packages that were previously administered by NHIF, under SHA, we have 18 benefit packages, an increment of 80%, which is a record in itself. Now, the other thing that was rolled out during the rollout was the new contribution structure. Allow me to delve a bit on the contribution structure.
Yes, please.
Under SHIF, contributors are classified into three broad categories. The first one being what we call salaried households. For the salaried households, these are people in gainful employment, they will contribute an equivalent of 2.75% of gross salary or wages. Now, the second category is the non-salaried households. These are mama mbogas, boda, artisans, retirees, and many others. Now, under the SHIF Act, their contributions are equivalent to 2.75% of the assessed income through what we call proxy means testing. Now, proxy means testing is an economic indicator tool that assesses the income, assets and liabilities of a member, and it's a tool that is used to determine two things. Number one, proxy means testing is used to determine the poor and vulnerable. Under the SHIF Act, the national government and the county government, for the first time, are obligated to set aside funds to pay for the poor and the vulnerable, whom we refer to as indigents. And for the national government, the money is apportioned from the exchequer. The third cadre of contributors is the sponsored programs.
Okay.
These are people basically who cannot afford to pay premiums, the poor of the poor. And as I said, the government is obligated to sponsor them, and the county government. Of particular note is that for purposes of identification of this poor and vulnerable, it is through proxy means testing. Now, this proxy means testing tool has been developed, among others, by the State Department Social Protection, the Ministry of Health, in collaboration with the county government. And the statutes indicate that SHA shall use the means testing tool, which will be reviewed periodically as we move on progressively. Yes.
Okay, well explained there. Now, there have been questions, from members of the public, those who were registered under NHIF, who are yet to register themselves on SHA, on whether the data is automatically transferred to NHIF, or do they have to register again?
Thank you, Vivian. That is a very important question. Remember, in the initial SHIF Act, Section 13, which talks on registration, it expressly stated that the former members of the National Health Insurance Fund were to undergo fresh registration. But the government is a caring government and a listening partner. Owing to petitions that were filed by members of the defunct NHIF, there was a request that their data be automatically transitioned to SHA. And the government did an amendment to the SHIF Act through Legal Gazette Notice number 147. And through that Gazette Notice, it expressly stated that the former members of the defunct NHIF were to be subjected to external verification by other state agencies. In this case, the state agency is the National Registration Bureau, which is the single source of truth. And I'm happy to report that their data was transitioned to SHA. But of particular note, I want to appeal to members of the public. We did write bulk SMSs informing them that their data had been transitioned. Additionally, we went further to appeal to those members to proceed and log in to the SHA portal to complete the process by updating details. And you might have noticed sometimes you hear people saying that they've gone to hospitals and their data cannot be seen. Part of the reason is that some of these members who are transitioned have never logged into the SHA portal to update their details. And when I talk of updating, we are talking of confirming their details, onboarding of the declared dependents. And when I talk of dependents, we are referring to the spouse, biological children arising out of that marriage, or adopted children that they have taken through a court order or a deed. And I'm to appeal to Kenyans. When you look at our database, God has been exceedingly good to us. We have 18.9 million members. But you note the number of declared dependents is around about 3.94 million. When you look at the average size of a family in this country, as per the Kenya National Bureau of Statistics, the average size of a family is 3.8, which we round off to 4. Mm-hmm. So ordinarily, in an ideal scenario, we should be expecting about 68 million dependents. Mm-hmm. Now, they say data is the new oil, and I say that in God we trust, other people must bring data. Mm-hmm. My appeal to viewers who are listening to me this morning, please proceed to the SHA portal. We've made the declaration of dependence very easy. It's done through the online portal, afyayangu.go.ke. Proceed to submit the required documentation. One, if you are married, a copy of the marriage certificate. Mm-hmm. Number two, if you have children, please scan copies of either birth notification for children below the age of 6 months, a birth certificate for children above the age of 6 months. Mm-hmm. For persons with disability, children with disabilities, there is a copy, a certificate that is issued by the National Council for Persons with Disability, okay, amongst others, mm-hmm, which you will onboard as you declare your dependence. Mm-hmm. Yeah. Okay.
Clearly, most people haven't, onboarded their dependents, looking at the numbers that you've just mentioned. And I've actually, while I was speaking to one of my producers, he mentioned that, while while declaring some of the dependents or onboarding some of his dependents, as a family man, one of their daughters has just gotten to the age of 18, but they don't have their ID just yet, so they were not able to onboard the daughter on it. So maybe how to go about that. For example, if that daughter, God forbid, needs medical attention at this time, clearly they will not be covered by SHA. So how to go about such?
Thank you, Vivian. The process of declaration of dependence, mm-hmm, is very easy. As I mentioned earlier on, you only need to log into the Afya Yangu portal. Yeah. But for children above the age of 18 years, mm-hmm, and currently you realize children are in school up to the age of 24, 25 years. Mm. SHA has provided a reprieve. In SHA we say, Mungu akileta mtoto, analeta na sahani yake. Sahani yake ni SHA. So what we've done, those parents who have children above the age of 18 years need to first of all ensure those children are enrolled to the SHA portal. Remember, under the new statutes, all persons need to be enrolled. Mm-hmm. So first of all, they have to be enrolled as young adults and get a SHA number. Mm-hmm. Number two, they need to get documentation indicating that these children of the age of 18 years and above, up to the age of 24, are in a full-time post-secondary institution. They could be in a technical university, they could be in a college, and it should be a full-time college. Mm-hmm. Thereafter, they can proceed and either visit the nearest point of service or onboard those documents online, mm-hmm, for purposes of allowing these children to get access to healthcare services. Okay. As I said, the Bible tells me in the book of Hosea 4 verses 6 that my people perish because of lack of knowledge. Mm. We are here today to help you understand the SHA processes, including the declaration of dependence, including registration, including proxy means testing, which is the tool that is used to determine indigents and premiums for the non-salaried households.
Okay. What are some of the services, the range of services that are under the Social Health Authority?
Thank you. Allow me to delve deep to take Kenyans through a journey on the expanded scope of services. When you look at the expanded scope of services, there are 18. And I want to tell Kenyans that SHA offers services under 3 tiers. The first tier being the Primary Healthcare Fund, or PCN, Primary Care Networks. Mm-hmm. Under the Primary Care Networks, we have 4 services that are available. Mm-hmm. The first one being the outpatient services. Under outpatient, we are talking of treatment of chronic conditions, consultations, requisite laboratory investigations, vaccinations, as per the Kenya External Vaccine Program. We are talking of outpatient procedures, dressing, suturing, amongst others, management of mental condition, health and wellness. You cannot talk of universal health coverage without talking of promotive, preventive healthcare, and that's why we talk of wellness. Finally, we are talking of guidance and counseling and antenatal and postnatal care. Now, allow me to share this with Kenyans. The tariff for the outpatient primary care, what we call the provider payment mechanism, and in this case we are talking of the global budget at a rate of 900 shillings per person per annum. I repeat, 900 shillings per person per annum. Now, access rules, where do you get these services? Members can get these services in level 2, 3, and select level 4 healthcare providers, which are primary healthcare referral facilities. Allow me to quickly take you through the primary healthcare inpatient medical services. Now, the scope of cover includes, of course, management of diseases while one is admitted. It also includes consultation charges, room and nursing care, laboratory investigation, radiology examinations, we are talking of X-ray amongst others, drug administration and dispensing, blood and blood products. And the tariff, or what we call per diem, is Kenya shillings 2,240 per day. And this is in level 2 and 3. And the access rules, you can be in hospital for a period of 180 days, what we call aggregate limits of liabilities. We also have screening services, which will be done as part of the initial assessment to identify potential health concerns. We are talking of arresting disease before it becomes terminal. And that's why a lot of emphasis has been put on preventive services. Okay. And the screening is for both common conditions that are financed and outpatient services, and targeted screening for the top 4 cancers with the highest incidences in this country. We are talking of prostate, we are talking of cervical, colon, and breast cancer, and this will be rolled in year 2 after maturity of the fund. Finally, we have the optical health services, which is eye health, and the scope of cover includes eye health education, wellness education, eye treatment, and prescription for refractive errors. We are giving glasses, and the tariff is 1,000 per household, strictly for beneficiaries below the age of 18 years, and it's available in level 2 to 4 facilities. That is PHC, and we've seen the 4 benefit packages. Allow me now to take you through the benefits that are financed under the Social Health Insurance Fund, which is the successor of the defunct NHIF. I'll move quickly because of time.
Yes, please.
Number 1 is the outpatient. Number 2, we are looking at the inpatient services. Number 3 is the maternity benefit package. Number 4 is the renal care therapies. And I didn't mention the scope of cover has been increased. Previously, under NHIF, we used to have hemodialysis, whereby we used to reimburse at 9,500 comprehensively. Under the new regime, it's been increased by 12% to 10,650, and we've introduced peritoneal dialysis. We have the highly patronized, the surgical benefit package, and when we are talking of surgical, we are talking of major, minor, and a specialized organ transplant, open heart surgery, total hip replacement, amongst others. We have the oncology benefit services for cancer treatment, mental wellness. Under COVID-19, we realized that mental health has become a challenge in this country. We have diagnostic imaging, including MRI, CT scan, PET-CT, and many others, oral health, and finally, we have overseas treatment or foreign treatment, which is provided for patients who cannot be treated ordinarily within the territorial boundaries of Kenya, who seek further treatment in overseas jurisdictions. Most commonly it's in India. Finally, allow me to talk something on the emergency chronic critical illness fund. which is provided for among the acts that Parliament provided. It provides for 4 benefit packages. Number 1 is ambulance evacuation services. Number 2 is chronic illness services. Number 3 is assistive devices. Number 4 is critical care services. And last but not the least is palliative healthcare services.
Okay.
Allow me to say this. How does this benefit package meet the needs of Kenyans? I know many people have been asking that question. Number 1 is universal coverage. Ensures access to both primary healthcare services, specialized healthcare services. Number 2, equitable access. We are saying there is equity in contribution, 2.75% across board. We are talking of not punishing the low-income earners, but what we are saying, the high-income earners will support the low-income earners by contributing 2.75%. Financial protection. The aim is to reduce out-of-pocket catastrophic healthcare expenditure, which improvises about 1 million families into poverty. We are talking of comprehensive care. It covers preventive, curative, and rehabilitative care, and improved accessibility nationwide. And you can register through either the SHA service points, and for that matter, we have 70 branch offices. We are available at Huduma centers and in some satellite offices. Thank you.
All right. Now, clearly, you know, with the range of services that you've just pointed out and the benefits that members should be getting out of SHA, it is something that should be beneficial and should be a good thing for Kenyans. But why is there public outcry? I'm sure you are aware that, you know, the people are not saying good things about SHA. You know, most people are saying it's not working. And there's public outcry overall. Just why is that the case? And are you aware of that?
Thank you, Vivian. We are aware. Indeed, we are aware of some of the challenges that have arisen, but I want to assure the public that SHA is working overdrive to address their needs. We are a listening partner. Perhaps allow me to delve a bit deeper on why we are having a bit of challenges. The first one being declaration of dependence. I did mention at the commencement of this program that we have scenarios whereby the principal members have registered, but unfortunately, due to one reason or another, they forgot to declare their dependents. That is the spouse and children. They only remember that they cannot access services at the point either the spouse or children are seeking services. And sometimes it has happened, we have gotten calls of people admitted in hospitals, and when we query our database, we realize that they had not been onboarded. This is very common, especially for the former members of NHIF who were transitioned to SHA and they were requested to update their details. The other thing we have noted is that sometimes when employers submit the monthly payroll byproduct, what we call the e-slip or the payroll registration number, PRN number, some of the people who make returns capture or miss one digit of an ID. And as such, you find that they've made returns using the correct name but the wrong ID number, and it is rejected in the system. The third reason is sometimes when employers fail to remit in the time and manner prescribed. The date due for SHA premiums is on or before the 9th of the following month. This is February. We expect February contributions to be paid to SHA accounts on or before 9th of March 2025. The other thing we have and which we are addressing is incomplete information. We have employers who remit the monthly payroll byproduct, and they remit through what we call real-time gross settlement, RTGS, or electronic funds transfer, EFT. There is a narration that is provided for, and some of them erroneously fail to indicate the unique identifier. In this case, the payroll registration number that is recognized in our portal. So you end up having scenarios whereby Payments have indeed been made, but they are incomplete or hanging in the system. To address some of these challenges, we have taken a proactive stance whereby our registration and compliance officers have been tasked to follow up with such employers with a view of undertaking reconciliation. We are also doing bulk SMSs and emails to employers, telling them to ensure that they submit the byproduct in the manner and time prescribed. Above all, on a week ago, we have come up with a query product whereby you can go to the SHA portal, log in, and it will be able to tell you the status of your contribution. We are currently sharing, and we are telling all our members to currently check their contribution status proactively so that we can arrest any challenges on time. I want to assure the public that the SHA administration is working round the clock. We hear you, and it's our hope and prayer we'll be able to address all the issues that you've raised in the fullness of time.
Yeah, you've clearly stated the benefits for chronic and critical illness patients, you know, and we've also seen complaints from some dialysis patients who are complaining that, you know, when they go to some of these facilities and their members, you know, and they've registered for SHA and they're paying, you know, and when they get there, they are required to now pay cash. You've actually even talked about the benefits being increased from what NHIF was giving, especially for the dialysis. There's an increase. But where is the problem? Is it a disconnect between SHA and the facilities, the hospitals? Or where exactly could there be a problem in that?
Thank you, Vivian. I hear you. We have instances whereby, as you correctly said, some patients perhaps are turned away. I want to look at it in a twofold way. Operational, where I've said either their contributions have not been updated, that they are not members of regular and good standing. When we describe a member of SHA, he is one who has remitted contributions up to date. But I want to look at it from the hospital side. Because we have provided the hospital portal whereby the hospital can be able to tell who is a member of regular and good standing. And the contracts that we've signed with all healthcare providers are very clear that they shall offer services as per the scope of cover. In this case, we are talking of dialysis unit. They are supposed to offer services unless otherwise. So in event our members are turned away, we have a quality assurance department that looks at issues to do with the scope of services, whether the healthcare providers are adhering to the scope of services. And I want to tell the public that SHA has gone out of his way. We are currently reimbursing claims, and I'm privy to the fact that we will be paying claims, and providers are receiving money as we speak currently, up to 31st December. 2024. So providers are implored upon to offer the scope of services. And we have offices across the country. In event you are unable to get services, you can visit the nearest point of service, and we are talking of 70. We are available in the counties, sub-counties. We have also set up offices at some healthcare provider level 4, 5, and 6 hospitals across the country. The other thing they can do, they can reach us on the toll-free line. They can call and make inquiries.
What's the line?
It is 08,000 620 720.
08,000 620 720.
Yes.
Okay.
The other thing I want to tell our members is that knowledge is power. It's imperative they log into the SHA website to get the scope of cover. Because it is when they're equipped with such knowledge, they can know what is their entitlement. It's very imperative. We're also doing feedback surveys, whereby we do baseline surveys to assess the quality of care that is administered to our members. It's not enough to get health care, but it must be quality health care that will translate to good outcomes.
Sure. Yeah. So you do monitor the effectiveness
Yes,
of
health
services.
There is a whole department called Quality Assurance that does clinical audits. They do random sampling, they interrogate the claims submitted. Before you access services, authorization, what I call prior approval. When hospitals launch requests, there are those team checks to confirm that it conforms to the treatment plan. Yes.
All right. Okay, and on that note, taking a break. Don't go too far because we'll come back. Okay, I've been asked to continue. So maybe what determines the type of care?
Now, let me answer that. First of all, we need to understand what we call the level of care that is administered in this country. And it's primary care network up to level 6, which are teaching and referral hospital.
Yeah.
Under or primary care centers, which are in level 2, dispensaries, their key is that they provide preventive, promotive, and basic curative services. They serve as the first stop of members seeking outpatient services. And the scope of service that they offer include outpatient care, consultation, diagnosis, and minor treatment, management of acute and chronic conditions, diabetes, hypertension, screening services, routine checkups. They offer vaccination and mental health. The other thing they do is minor outpatient procedures. Now, in sufficient treatment and they feel that you require further treatment, then you automatically to higher level facilities, what is known as secondary care facilities. That is facilities in level 4 and 5. Which include county referral hospital. And these county and sub-county hospitals provide most advanced care than primary care centers, and patients are referred here for specialized outpatient and inpatient care. The scope of services for secondary care services include advanced outpatient and inpatient services, surgical procedures. We are talking of cesarean sections, orthopedic surgeries, amongst others, comprehensive maternity, neonatal and child health care services, renal care therapies. We are talking of dialysis and the kidney treatment, cancer care treatment, chemotherapy, radiotherapy, mental health treatment and psychiatric services, medical imaging and diagnostics. That is, we are talking of CT scans, MRI, ultrasound. Specialized care, we are talking of cardiology, neurology, orthopedics. And as I said, these are in level 4, 5. Now, we have the last one, which is level 6, which is basically offering specialized services, the entire scope of specialized services. And when we talk of level 6, we are talking of facilities like the Moi Teaching and Referral Hospitals, Kenyatta National Referral Teaching Hospital, Jaramogi Oginga Odinga Referral and Teaching Hospital, and many others. Now, these ones offer specialized access services. Yes, now finally, there's the chronic critical care. And I said that for the issues of emergency chronic care, for emergencies, all Kenyans are entitled to treatment. Now, irrespective of the payment status. Now, when it comes to chronic critical illness funds, it is for SHA who have depleted. My appeal to you this morning is that for patients who ail from chronic critical illness, diabetes, kindly, I implore you to register to SHA so that you can get this life-saving medication, and even of liabilities, you'll
Okay. To what extent exactly is SHA funding, medical needs of its members or the patients? To what extent is it funding? We know that, with NHIF, at some point it was, when one is admitted, it used to cover just the bed fees, so to what extent is SHA funding?
Thank you, Vivian, for that very important question. SHA is catering for the medical needs of Kenyans. And to the extent, I want to say comprehensive. Why do I say? You can see that the scope of cover has been extended from the 10 benefit package to 18 benefit packages. And it has witnessed the introduction of an additional 8 benefit packages that were not there. Allow me to just mention briefly. We've come from a regime whereby we did not have the critical care. I'm talking of ICU, HDU, which is currently being covered. Under ICU and HDU, SHA reimburses as per the daily, what we call the rebate, daily rebate. A case in time, if you are in a level 6 facility, then SHA is obligated to reimburse the daily rebate, which is 4,480. And we are able to cover that for a period of 180 days, which is the limits of liabilities. We are talking of assistive devices that were never there in the past. When we talk of assistive devices, you are talking of wheelchairs, crutches, pressure stockings. These are covered under SHA. We are talking of screening services. And I did indicate, for the first time, SHA will be catering for screening services, diabetes, hypertension, cancer, PSA counts, cervical, and many others. We are talking of evacuation, emergency evacuation. Evacuation from a point of a road traffic accident, stabilization, and transportation to the nearest empaneled and contracted healthcare facilities. We are talking of optical, dispensing of glasses for refractive errors. We are talking of dental treatment, root canal, tooth extraction, amongst many others. These are things that were not previously there. And because the government listens, Kenyans petitioned the government during public participation to include this range of services so that they do not suffer out-of-pocket catastrophic healthcare expenditure. Yes.
All right. Okay, I hear you on that. Now, the United States of America was a key supporter of Kenya's programs on combating different illnesses like HIV, tuberculosis, and malaria as well. Now that they have withdrawn from that, what are we doing as a country, or what are you doing as SHA to ensure that some of this medication will not be lacking? For example, ARVs, which are life-saving medication, and they are lifelong medications. So what measures have you put in place to ensure that we are not going to have an outage of some of these medications?
Thank you, Vivian. For your information, those are the vertical programs that were financed through the ministry. HIV treatment, we are talking of ARVs, tuberculosis, malaria, amongst others. I want to assure Kenyans that all is not lost. Those ailments are covered under SHA. Issues to do with malaria, medical inpatient, issues to do with HIV are covered. Issues to do with tuberculosis are covered. I remember under SHA, we used to have a program that we had a partnership with tuberculosis patients whereby they had a sponsor who used to pay for their premiums. What I want to tell Kenyans, for those patients who ail from those ailments, please, please, please ensure that you enroll with SHA so that you do not miss on the extended scope of coverage.
So they're well sorted under that. They should not fear of, them getting to a point where they're going for medication and the medication is no longer there.
We say at SHA, bima bora afya nyumbani.
Take your word on that. So probably as we almost come to an end of this, ensure the quality of healthcare services across all hospitals. about the surveys that you do, but just how entirely do you ensure the quality of healthcare services?
I hear you. Enough to administer care, but at SHA we say the care must meet the internationally accepted standards of quality of care. I did indicate we have the quality assurance department. This department is made up of clinical officers and nurses. And what they do is to review the nature of treatment that is being administered to our members. They check the clinical notes. They visit the healthcare facilities to confirm that they are offering the range of cover that they signed up to. The other thing they do clinical and service delivery benchmarks.
How often are these checks done, and do they go to all facilities under SHA?
Very important. We have quality assurance officers deployed at all 70 service points of SHA. And they have what we call a surveillance program, whereby they go to the hospitals to do two things. Number one, they do what we call hospital head count of the patients admitted at a facility on a given day. Number two, they review the clinical notes to confirm that it aligns with the treatment plan and the standard operating procedures. So they do it
oftenly?
Very oftenly.
Okay.
In fact, if not daily, they do it 3 times or 4 times in a week.
Okay.
So you will always see them visiting patients, talking to patients and asking them the nature of treatment offered to collect feedback for purposes of ensuring the quality of care.
Okay.
The other thing is the benefit package and standardized protocols. To guarantee the quality of care, SHA has a structured benefit package to cover a comprehensive range of services from preventive to specialized care. These services follow clinical guidelines, standard treatment protocols to ensure consistency and effectiveness. Number 3 is strategic purchasing of healthcare services. I hope we have time.
We should be finishing.
When we're talking of strategic contracting and provider performance monitoring tools, the SHA contracts, both public and private, ensure that we have a wide network of facilities across urban and rural areas. We also do baseline surveys.
Okay.
We do customer satisfaction index to get feedback from our loyal customers on the scope of services that they've received.
All right.
Yeah.
As we wind up now, we need to wind up. My last question to you, and I want you to answer me in the fewest of words. What is the state of the Social Health Authority as it stands right now?
Thank you for that very important question. The state of Social Health Authority.
In the fewest of words.
We have started and we are progressing well. What I want to tell Kenyans, UHC is not an event, it is a continuous journey.
Okay.
We have started and we are moving on well with their support and prayers. In the fullness of time, we'll be able to attain 100% attainment of universal health coverage.
All right. Thank you so much, Mr. Osoro, for joining us for this conversation. Now, that was Mr. Gilbert Mugambi Osoro, who is the head public education and awareness, and he was here to just shed light on the Social Health Authority. Remember, he's given out a free toll line. If you have any questions, if you have any issues concerning SHA, you can get through to them. It was 0800 2720. So you can reach out to them if you've got any queries concerning the Social Health Authority.
They can also reach us through our website, and we have a chat bot there. They can send questions through our Facebook, Instagram, and Twitter. We can always respond.
All right.
We can carry on with this conversation there.
Okay. This is where we end Good Morning Kenya for today. Thank you so much for staying tuned. My name is Vivian Dagwa. Do enjoy the rest of your viewing. Goodbye.